All right, let's get right to it. Diagnosing infective endocarditis isn't about a gut feeling. It's a high-precision calculation. So welcome to your masterclass on the modified Duke criteria.
We are about to run a full diagnostic blitz. In the next 60 seconds, I'm giving you the entire framework, so listen closely. Definite endocarditis needs 2 major criteria, or 1 major plus 3 minor, or 5 minor criteria. Got it? Major criteria, Pillar 1, blood cultures. We're talking 2 separate positive cultures with typical organisms like Staph aureus, Viridans group strep, or the Hayseck group. Major criteria, Pillar 2, imaging. That's echocardiographic evidence of a vegetation, an abscess, or new dehiscence of a prosthetic valve. Now for the minor criteria, a 5-point checklist. 1, predisposition, think intracardiac prosthesis or IV drug use. 2, fever, greater than or equal to 38 degrees Celsius. 3, vascular phenomena, think Janeway lesions. 4, immunologic phenomena, think Osler nodes. And 5, microbiological evidence that doesn't quite meet the major criteria. You need to know these pillars. You have to do the math.
Now, before we proceed, we must issue the mandatory international medical disclaimer. The following content is provided for educational and board review purposes only. It is not intended as and shall not be understood or construed as medical advice. All clinical decisions require consultation with official published guidelines and a qualified supervising physician.
Okay, now for the deep dive. Sarah, let's really break down the major criteria. They're the absolute bedrock of this diagnosis, but you'd be surprised how often they're misinterpreted. For blood cultures to really count, what's the one non-negotiable rule? It's what we call the 2 and typical rule, Dr. Collins. You absolutely must have 2 separate positive blood cultures with those typical organisms. Now, there's a key exception you have to know. For Coxiella burnetii, just a single positive blood culture or an IgG antibody titer over 1 to 800 counts as a major criterion. That level of precision is critical. And speaking of the second major pillar, imaging, the 2023 ESC Guidelines have completely changed the game. I mean, it used to be all about the echo, but now PET-CT and cardiac CT have been elevated to major criteria status, specifically for cases with prosthetic valves where they show abnormal activities suggesting infection. This is a huge paradigm shift, especially for those tough culture negative cases.
That is an absolutely critical point of clinical significance. And let's be crystal clear on another huge 2023 ESC update, a new valvular regurgitation that you spot on an echo that is no longer just a minor finding. It is now, without a doubt, a major criterion.
Excellent. So let's move on to the minor criteria. These are so often the tiebreakers, They're the subtle clues that really help solidify a complex diagnosis. And believe me, they are a favorite testing ground on board exams.
Okay, the 5 minor criteria are as follows. Number 1, predisposition. So that could be a pre-existing valve condition or a history of IV drug use. 2, fever, specifically at or above 38 degrees Celsius. 3, vascular phenomena. 4, immunologic phenomena. And number 5, microbiological evidence that is positive but doesn't quite meet those strict requirements for a major criteria. And here's the key to telling points 3 and 4 apart. Vascular phenomena are the direct result of emboli, and because of that, they are painless. These are your Janeway lesions. Immunologic phenomena, on the other hand, are immune complex mediated, and they are painful. Those are your Osler nodes. Seriously, remembering painless Janeway versus painful Osler is absolutely essential.
Perfectly articulated. All right, Sarah, let's bring it all home. Give us the final diagnostic calculation for definite infective endocarditis.
A definite diagnosis is met with 2 major criteria. Or you can have 1 major criterion plus 3 minor criteria. Or, finally, a total of 5 minor criteria.
Right. And any combination below those thresholds, like 1 major plus 1 minor or just 3 minors on their own, only meets the criteria for possible IE. And this distinction is everything. It's what decides if a patient starts 6 weeks of IV antibiotics, so you have to get the math perfect.
Which brings us right to our question of the day. In your own clinical experience, have you ever had a patient with suspected endocarditis where the blood cultures just kept coming back negative, but a PET-CT scan was the one thing that unlocked the definitive diagnosis? We'd love to hear it. Share your case in the comments below.
Okay, now to make sure this calculation is permanently burned into your memory, prepare for the Duke criteria chant.
2 major is sure. 1 plus 3
starts the cure.
5 minor makes it pure.
Culture, echo. PETCT is new. The guidelines, review.
And there it is. The math is locked in. 2 majors, 1 and 3, or 5 minors. These combinations are absolute.
Excellent. So the diagnostic criteria are mastered. But recognizing a Janeway lesion from an Osler node at the bedside, that's a whole different skill set. So subscribe and join us for Module 3, where we dive deep into the peripheral science and the physical exam.